Cholesterol discussions typically generate anxiety despite the fact that cholesterol itself serves essential physiological functions. The body requires cholesterol to build cell membranes, produce steroid hormones including testosterone and cortisol, synthesize vitamin D, and create bile acids for fat digestion. Problems arise not from cholesterol's presence, but from its excess. When cholesterol levels exceed what the body requires for these functions, the surplus accumulates in arterial walls, initiating atherosclerotic plaque formation that narrows vessels and restricts blood flow. Approximately 10% of American adults have high cholesterol, a condition that substantially increases cardiovascular disease risk. The insidious nature of cholesterol accumulation is that it occurs silently over years or decades without producing symptoms until arterial blockage becomes severe enough to cause heart attack or stroke. This asymptomatic progression makes cholesterol screening essential for early detection, creating an intervention window when lifestyle modifications or medication can prevent or slow disease development. Standard cholesterol panels measure multiple values, including total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. While all these numbers provide information about lipid metabolism, two values carry the most predictive power for cardiovascular risk: LDL cholesterol and non-HDL cholesterol. Understanding what these numbers represent, why they matter more than other cholesterol measurements, and what target ranges should be achieved provides a foundation for cardiovascular disease prevention. LDL cholesterol, the primary atherogenic particle. Low-density lipoprotein cholesterol, commonly called bad cholesterol, measures the cholesterol content carried within LDL particles. These lipoproteins transport cholesterol from the liver to peripheral tissues throughout the body. When LDL particles circulate in the bloodstream, some penetrate the endothelium, the single-cell layer lining blood vessel walls. Once inside the arterial wall, LDL particles can become oxidized through interaction with reactive oxygen species. Oxidized LDL triggers an inflammatory response. Immune cells, including monocytes, migrate into the arterial wall and transform into macrophages that engulf oxidized LDL. These cholesterol-laden macrophages, called foam cells, accumulate and form fatty streaks, the earliest visible stage of atherosclerosis. As this process continues, smooth muscle cells migrate into the area, additional lipids accumulate, and a fibrous cap forms over the growing plaque. The plaque progressively narrows the arterial lumen, restricting blood flow. More dangerously, the fibrous cap can rupture, exposing the lipid-rich core to circulating blood and triggering rapid clot formation that can completely occlude the vessel, causing heart attack or stroke. The direct relationship between LDL cholesterol levels and atherosclerotic plaque formation has been demonstrated through multiple lines of evidence, including epidemiological studies, genetic research on familial hypercholesterolemia, and randomized controlled trials of cholesterol-lowering medications. This evidence consistently shows that reducing LDL cholesterol slows plaque progression and reduces cardiovascular event rates. The relationship is continuous. Lower LDL levels produce progressively lower risk without an apparent threshold below, which further reduction provides no benefit. Target LDL levels depend on overall cardiovascular risk. For individuals at average risk without additional risk factors, an LDL below 100 milligrams per deciliter is generally considered acceptable. For people at higher risk due to diabetes, established cardiovascular disease, strong family history, or multiple risk factors, more aggressive targets apply. High-risk individuals often aim for LDL levels below 70 milligrams per deciliter, and very high-risk patients, such as those who have had recent heart attacks, may target LDL below 55 milligrams per deciliter. Non-HDL cholesterol, capturing total atherogenic burden. Non-HDL cholesterol represents total cholesterol minus HDL cholesterol. This calculation captures the cholesterol content of all potentially atherogenic lipoproteins, including LDL, very low-density lipoprotein, intermediate-density lipoprotein, and lipoprotein A. Each of these particle types can contribute to atherosclerotic plaque formation. Measuring only LDL misses the contribution of these other atherogenic particles, potentially underestimating cardiovascular risk in people with elevated VLDL or other non-LDL atherogenic lipoproteins. VLDL particles carry triglycerides from the liver to peripheral tissues. In the bloodstream, VLDL particles progressively lose triglycerides through the action of lipoprotein lipase, eventually transforming into LDL. People with high triglycerides have elevated VLDL levels, meaning they have more atherogenic particles circulating than LDL measurements alone would suggest. Non-HDL cholesterol accounts for this by including VLDL cholesterol in the total. The practical advantage of non-HDL cholesterol is that it can be calculated from a standard lipid panel without requiring fasting. LDL is typically calculated using the Friedewald equation, which requires a fasting sample because it relies on triglyceride measurements that vary substantially with recent food intake. Non-HDL simply subtracts HDL from total cholesterol, values that remain relatively stable regardless of fasting status. This makes non-HDL a convenient and reliable marker for assessing atherogenic cholesterol burden. Target non-HDL levels are generally set 30 mg per deciliter higher than LDL targets. For average risk individuals, non-HDL below 130 mg per deciliter is acceptable. For higher risk individuals targeting LDL below 70, the non-HDL goal would be below 100 mg per deciliter. Some guidelines suggest even lower targets for very high-risk patients. Why these numbers matter more than total cholesterol? Total cholesterol provides limited information about cardiovascular risk because it combines both atherogenic and protective cholesterol. Someone with very high HDL might have elevated total cholesterol despite low risk. Conversely, someone with low HDL and moderately elevated LDL might have acceptable total cholesterol while facing elevated risk. HDL cholesterol alone has proven less useful as a treatment target. Medications that raise HDL have not consistently reduced cardiovascular events in clinical trials. The focus has shifted to lowering atherogenic particles. Triglycerides function more as a marker of metabolic dysfunction than a direct cause of atherosclerosis. Elevated triglycerides often accompany insulin resistance and metabolic syndrome. Very high triglycerides require specific treatment to prevent pancreatitis, but moderate elevations are less directly threatening than elevated LDL and non-HDL. Screening frequency and risk assessment. Cholesterol screening recommendations vary based on age and risk factors. Men in their 40s and 50s without known risk factors generally require screening every 1 to 2 years if previous results were normal. This frequency allows detection of changes while avoiding excessive testing. People with risk factors including diabetes, hypertension, family history of premature cardiovascular disease, or current smoking require more frequent monitoring, typically every 6 to 12 months. Individuals already taking cholesterol-lowering medication need periodic testing to assess treatment effectiveness and guide dose adjustments. The goal is to achieve target levels while using the minimum effective medication dose. Cardiovascular risk assessment incorporates cholesterol values alongside other factors including age, sex, blood pressure, smoking status, and diabetes. Risk calculators like the pooled cohort equations estimate 10-year risk of cardiovascular events. These estimates guide treatment intensity, with higher risk individuals warranting more aggressive cholesterol targets and earlier consideration of medication. Treatment approaches for elevated cholesterol. Lifestyle modifications form the foundation of cholesterol management. Dietary changes emphasizing reduced saturated fat, increased fiber, and foods containing plant sterols can lower LDL by 10 to 15%. Regular aerobic exercise improves lipid profiles. Weight loss in overweight individuals improves all lipid parameters. When lifestyle changes prove insufficient or cardiovascular risk is high, statin medications provide effective LDL lowering. Statins inhibit cholesterol synthesis in the liver, reducing LDL by 30 to 50%. Additional medications including ezetimibe and PCSK9 inhibitors can be added for patients requiring greater reduction. Cholesterol, specifically LDL and non-HDL, represents a modifiable risk factor. Early detection through screening and appropriate intervention can substantially reduce cardiovascular disease risk.